Okay, sure.
This meeting is being recorded.
Okay, so it's a very big pleasure and honor to interview Dr. Padhraig Fleming. I've been reading his papers for quite a while, and we wanted to ask Dr. Fleming on the pendulum swing between extractions and non-extractions, since it's been an ongoing debate for the last 100 years at least. And I wrote a few questions for Dr. Fleming. First question would be, what are your thoughts on the pendulum between extraction and non-extractions?
Thanks, Miguel, and thank you for the invitation. It's very nice to meet you. I guess it is a pendulum that continues to swing, but is one that is very much, I would say, in the non-extraction kind of side at the moment. I think, there's been a lot of philosophical debate around the relative merits of extractions and non-extraction based approaches, as we know, but I think what we cannot lose sight of really is the biology and the anatomy, and that hasn't changed markedly over the years while our philosophies have. And by that I mean, there is, a fairly fixed dimension, in terms of the jaw bones themselves. Tooth size has been relatively fixed, over the past century or so, and yet our extraction decisions have fluctuated. And that all points to really philosophical approaches, being the key determinant of our decisions. If anything, the prevalence of crowding, as we know, has probably increased over the past, a number of generations. And yet, the tendency for us to extract seems to have reduced. So there's a disconnect there, I think, between the biology, the anatomy, and our decision making. And I suppose what interests me, as a clinician, is why is that disconnect there? One study that we published recently ourselves is one that was trying to understand, clinicians' decision making a little bit better around extractions. And what I feel is, that while we are extracting less, those kind of mechanical approaches, which maybe might facilitate non-extraction based treatment, are not necessarily, for example, the main reason why we're extracting less. So it's not as though, as a group of practitioners, certainly in the UK and in Europe, that we're perhaps distalizing more to facilitate non-extraction based approaches. We're also not retaining things differently. So we're not, even despite extracting less, we're not using more fixed retention, for example. So I kind of wonder with this approach, are we potentially, breeding quite an unstable orthodontic generation, given that, as I said, biology and anatomy hasn't changed and our decision making seems to be, more and more towards that non-extraction based approach.
Excellent. Then the next logical question would be, do non-extraction lead to other problems such as posterior crowding or second molar impactions? In these cases that are borderline, when you have to make a decision whether or not to extract, let's say, second premolars, what are your thoughts on that? Because we get to see these patients and we, quote unquote, develop the arches and make arches wide, and we fit all the teeth from first molar forward. But then what happens with the second molar? And the other question would be, if extractions of third molars are not also an extraction treatment, because third molars are as well.
Yeah, absolutely. No, I contend that they are, Miguel. And, one philosophical kind of consideration that I have around treatment is that, I don't like to see patients losing 2 units per quadrant. And I consider a third molar to be a unit. I do wonder, with non-extraction based approaches, whether we are increasing the likelihood of posterior crowding, second and third molar, particularly third molar impaction. And I think that probably is true. I think in terms of finding definitive evidence around that, it's really difficult. We don't have, very good kind of prospective long-term evaluation, of the effect of, be it extraction or non-extraction based approaches on eruption and position of second and third molars. But it would be intuitive to expect that if we're extracting less, we're likely to see more posterior crowding. So, in reality, there is a fixed arch length that is available to us. There are anterior and posterior limits of dentition. And I think we should be factoring in those posterior limits in our extraction decisions as well, without question.
The next logical question is, if premolar extractions have a place, are a valid treatment choice in contemporary orthodontics, despite this big pendulum swing towards non-extraction, what are your practical guidance for deciding on extraction or non-extraction? In simple words, when do you decide to take out teeth? And the other thing is, many times these non-extraction approaches involve more invasive treatments. We use mini plates, we use mini screws, we use infrazygomatic tats, we use tat expansion. So how do you decide, what are your guidelines, and when really treatment is more complicated, non-extraction than extraction, and what are your thoughts on that?
Yeah, really good question, Miguel. I mean, I would say you're right. It can be sometimes a little bit more invasive, to treat patients without extractions actually than with extractions. And I think with any patient, what we've got to consider is obviously the outcome that we want to achieve, but also the process that we've got to go through to get to that outcome. And sometimes, there is quite a degree of invasiveness, in particular with non-extraction based approaches. We've also, I suppose, got to factor in whether a non-extraction based approach truly is non-extraction. We've just already discussed, terminal molars, and whether in reality, we will ultimately be treating that patient without extractions in the longer term. I think what I try to base my extraction decisions on are fundamentals. We do use and we teach kind of space planning approaches, which I think are really helpful. And I, very much consider this concept of kind of health, aesthetics, and stability when I'm planning any kind of orthodontic treatment. And by that, I mean, for example, if we've got a patient with a large overjet, what are we aiming to do? Are we planning to retract the upper incisors, to advance the lower, to do a combination of those two movements? What informs our decision? Well, the relative impact of those changes in terms of, dental and facial aesthetics, perspective stability, and similarly in terms of periodontal health. And obviously we know that if we do things like advance the lower dentition significantly, we may potentially compromise periodontal health. So there are limits to dentition that we have to respect. So I do try to use kind of a formal space planning approach, when I'm planning treatment, and certainly when I'm teaching, orthodontic treatment. Around kind of fixed thresholds for extraction versus non-extraction, I think that's really difficult to specify. I think that's a $64,000 question. We did try to kind of, in one study that we did in the past, where we actually identified that 95% of British orthodontists are extracting less than they did 5 to 10 years previously. We tried to, suggest possible thresholds. And what we did find was that actually orthodontists are extracting less, and their kind of threshold for extraction seems to have increased by about 2 millimeters or so over the past decade. So if they've got a little bit more of a space requirement, perhaps they're more likely to extract, but that, threshold for extraction certainly has been raised over time.
And then the last question, which is a double question, is what are your thoughts on profile and extractions? In a well-managed extraction case, profile shouldn't change at all. And we know that from the studies, but there is a lot of pseudoscience going around extractions. And the other question would be, what are your thoughts on airways and extractions? Because that's another point where there is a lot of pseudoscience and a lot of confusion towards specialists and towards the general population. So what are your thoughts on both topics?
I'd say in terms of profiles and extractions, just as you said, Miguel, I think well-planned treatment, will result in improved, profiles. In reality, anytime I'm thinking about aesthetics, so I'm thinking about both facial and dental aesthetics, facial objectives and occlusal objectives. So clearly, if we've made a, reasonable kind of treatment plan with realistic objectives around placement of the anterior teeth, we will, typically improve the profile and certainly not harm it. So that really shouldn't be a concern with well-planned treatment. In terms of airways and extractions, I have to say my sense is there's no association whatsoever. I think there's certainly no evidence to suggest a causal link between extractions and airway issues. And my kind of general feeling on this type of kind of discussion is that even in orthodontics, we need to focus on what we can predictably change. And what we can predictably change is the position of teeth, the relationship of the, the upper lower arches to one another. These kind of downstream effects around things like airway, I think are very, very difficult to pinpoint. But similarly, if there is an effect, I think it's likely to be very, very minimal. There are a whole lot of other physiological kind of issues, which I think, trump actually anatomical effects, associated with the airway. but certainly trump kind of anatomical effects associated with the dentition, as it relates to airway effects. So, I have to say it is not a real concern. Perfect.
And just to end, just a few thoughts on relapse and stability. I know you've written a few papers on that, and I'm a firm believer in long-term fixed retention in the lower arch, but I would like to know, what are your thoughts on that, since you put on the work and you've written about it?
Yeah, no, I certainly am too, Miguel. I think, we can never kind of downplay the challenge associated with retention. It is, it's been, it's kind of a hackneyed statement these days, it is the problem in orthodontia, retention. So it's not simple, but I think, we have an obligation just as much to treat well as to retain well. And, and what I tend to suggest is, poor orthodontics requires excellent retention to maintain a good long-term outcome, but so does excellent orthodontics. It still requires excellent retention. Having said that, I think we know even from the work of Little and others that, if we do expand the arches significantly, we are much more likely, I think, to breed instability. So, I go back to what I talked about earlier on and respecting the limits of the dentition. I think that's important if we're to have a reasonable prospect, of a well-retained, good long-term outcome. But that does not mean that good retention is still not required. I believe that it is in pretty much every case that we treat.
Okay. So thank you very much for your time. And
no problem, Miguel.
I will share this interview, as I told you, on my YouTube channel. And this is a source of information for young orthodontists, and also in my social media, because I do have a concern about the boom in non-extraction, non-planified treatment, and what happens long-term. So thank you very much for your time. And
no, you're welcome, Miguel. Not at all.
Merry Christmas and all the best.
You too.
Thank you very much.
Not at all. Take care, Miguel.
Bye-bye. Thank you so much.
You're welcome, man. Bye-bye.